Welcome to the Deep Dive. We're the show that cuts through the noise, really digs into the research, and pulls out those nuggets of knowledge you need to give you that critical understanding.
That's right.
And today, we're plunging headfirst into a medical situation that can, well, unfold incredibly fast. It's a true emergency, requires quick thinking, quick action. We're talking about hypoglycemia.
Low blood sugar. It sounds simple, but it's anything but.
Exactly. And we're going to kick things off with a scenario, something really compelling that shows just how vital this knowledge is. So imagine this, a 56-year-old man. He's had type 2 diabetes for, say, about 12 years.
Okay, a long time.
Yeah, and he's just started on a new medication, one of those oral anti-hyperglycemic drugs, the ones meant to lower blood sugar.
Right, standard treatment often involves adjustments or new meds.
But then, bam! Out of nowhere, he shows up at the emergency department. He's drenched in sweat. Diaphoresis, I think is the term.
Diaphoresis, yes. Profuse sweating.
And his level of consciousness is way down. He's confused, maybe not making sense, maybe even totally unresponsive. It's genuinely alarming to witness.
Absolutely terrifying for anyone there.
Okay, so let's unpack this. What is actually going on inside his body? And maybe more importantly for our listeners, what do you do if you see this, if you're a family member or just, someone nearby?
What can you do? Yeah.
This deep dive, it's not just about textbook facts. It's about arming you, the listener, with the knowledge you need to understand this, to spot it, maybe even help out. It's about being prepared, knowing when to act. For others, maybe even for yourself.
That's exactly our mission today. We're going to navigate the intricate complexities of hypoglycemia, is what people just call low blood sugar.
Right.
We'll explore it all, the definitions, how it shows up, which can be tricky sometimes, the immediate treatments that save lives, and importantly, the long-term strategies to stop it happening again. The goal is for you to walk away with a really solid, practical understanding. Because believe me, when blood sugar crashes, every single second counts. Recognizing it fast, acting fast.
Yeah.
It's vital. It can honestly be the difference between a quick recovery and, well, a devastating outcome.
And when you say rapid action, you really mean it. In an emergency like the one we described, someone suddenly confused, consciousness dropping, there's a very specific protocol, isn't there? When that patient hits the ER doors, what are those first absolute must-do steps? Sounds like there's zero time for a leisurely history taking.
You are absolutely right. Time is everything. The detailed history, that often has to wait. When you've got any unstable patient, especially someone with a decreased level of consciousness, we immediately jump into what's called the ABCDE approach. It's foundational.
ABCDE.
Yeah. So first is airway. Is it open? Clear? Can they actually breathe?
Makes sense.
Then breathing. Is it adequate? Are they getting enough oxygen in? We check that right away.
BB.
Then circulation. Check their pulse. Look at their perfusion. Are they getting blood flow? These are the absolute non-negotiables to stabilize anyone in critical condition.
Got it. Airway, breathing, circulation, the basics.
Exactly.
Yeah.
Now, once those are secured, for someone like our patient where you suspect hypoglycemia, getting IV access is critical, like immediately.
IV access. Why so urgent?
Well, we need a direct line. We're talking about quickly putting in 2 large bore cannulas, think 16 or 18 gauge needles into a vein. This isn't just for fluids. It's the highway for getting life-saving meds in fast, like IV dextrose.
Okay. Direct delivery.
Precisely. And maybe the single most crucial diagnostic step right then and there, something we do for all patients with altered mental status, is an immediate capillary glucose check.
The fingerstick test.
Yep, that simple finger stick. It's often the fastest way to answer the burning question. Is low blood sugar the culprit? You get an answer in seconds, not minutes. It's the absolute cornerstone of diagnosis in this kind of emergency.
That instant check makes total sense. Confirm the problem before you fix it. But thinking back to our 56-year-old guy, what could have led to that sudden scary drop? What kinds of things precipitate this? What are the common triggers?
That's a really important question. Understanding the triggers is key to preventing it happening again. In his case, a huge suspect is that recent medication change, especially if he started or had his dose increased on a sulfonylurea.
Sulfonylurea, you mentioned those earlier.
Right. They're common oral meds for type 2 diabetes, and they work by pushing the pancreas to release more insulin. If the dose is too high for his needs right now, or maybe he skipped a meal after taking it, poof, blood sugar can plummet. It's a classic scenario, unfortunately.
Okay, so meds are a big one. What else?
Well, beyond meds, other things significantly raise the risk. Problems with the kidneys or liver-impaired renal or hepatic function. Those organs are vital for clearing meds. And the liver, specifically, is key for managing glucose stores. If they're sluggish, meds hang around longer, Glucose control goes haywire.
Okay. Kidney and liver function.
Definitely. Alcohol use is another big one, often overlooked. Alcohol directly messes with the liver's ability to release stored glucose. So if you're on diabetes meds, drinking can be really dangerous.
I didn't realize it was that direct.
Oh, yeah. Then you've got things like infections, any kind of major trauma, even certain endocrine disorders, problems with hormone glands. They could all throw the body's metabolic balance off and trigger hypoglycemia.
Wow. So lots of potential factors.
Absolutely. But for our patient, that new oral anti-hyperglycemic regimen would set off alarm bells immediately for any clinician. The risk is just well known with certain drugs.
So, okay, you've done the finger stick. It's confirmed low. The treatment isn't just one thing, right? You said it depends on the patient's state. How do you decide what to give? What are the different approaches?
You're absolutely spot on. The strategy really hinges on their neurological status. If the patient is alert and oriented, fully conscious, answering questions, able to swallow safely, then the go-to is oral glucose.
Something they can eat or drink.
Exactly. Usually about 15 to 20 grams of fast-acting carbs. Glucose tablets are ideal because they're measured and work quickly.
Like those chalky tablets.
Those are the ones. But if you don't have them, a small glass of fruit juice, maybe a tablespoon of honey, even some hard candies, not chocolate though, the fat slows it down, can work.
Okay, 15, 20 grams. Then what?
Then, the crucial follow-up, and this is vital for patients and families to know, recheck their blood glucose in 15 minutes. If it's still under 70 milli-GDL, you give another 15, 20 grams. We call it the 15-15 rule. It's a cornerstone for managing milder episodes at home.
15 grams, wait 15 minutes, repeat if needed. Got it.
Perfect. Now, for patients like our initial case, altered mental status, unconscious, or just unable to swallow safely, we have to go parenteral, meaning not through the mouth.
Right, IV or injection.
Correct. The gold standard in the ER is intravenous IV dextrose. Usually adults get 25 grams. There's a common way is giving 50 milliliters of a 50% dextrose solution. It's very concentrated, gets a lot of sugar into the bloodstream fast.
D50, I've heard that term.
Exactly, D50. You might also see D25 or D10 in larger volumes, depending. But the goal's the same, rapid, direct glucose. For kids, the doses are very carefully based on weight, like 1 ml per kilo of D25 or 2.5 milliliters per kilo of D10. You have to be precise with children. And you might repeat after 15 minutes if needed.
Okay, IV dextrose if possible. What if you can't get an IV right away? Or if someone's at home?
Great question. If IV access is delayed or if you're outside the hospital and the person has it prescribed, glucagon is the answer.
Glucagon, that's a hormone, right?
Yes, it's a hormone the pancreas makes naturally. It basically tells the liver, release your stored sugar now. It counteracts insulin.
So it raises blood sugar from the inside, essentially.
You got it. The dose is usually 1 milligram, given as an injection into the muscle, IM, or just under the skin, SQ. For anyone weighing 25 kilos, about 55 pounds or more, if they weigh less, it's half that, 0.5 milligrams.
And families can be trained to give this.
Absolutely. It's a critical rescue tool for paramedics, but also for trained family members when someone is unconscious and can't take sugar by mouth. It's a literal lifesaver.
That's incredibly helpful to know. So, okay, you've given the dextrose or glucagon, their glucose is coming up, they're looking better. Is that it? Done? Or is there a risk of it just dropping again? Seems like you'd need to keep watching.
Absolutely not done. That initial treatment is just step one, the immediate firefighting. It is incredibly important to monitor them regularly afterwards for what we call rebound hypoglycemia.
Rebound, it comes back down.
It can, yes. Think of it like pouring water into a leaky bucket.
Yeah.
You filled it, but the leak's still there. Especially if the cause was a long-acting drug like a sulfonylurea. That drug might still be working in their system for hours, pulling the sugar back down.
Ah, right, because the drug hasn't worn off yet.
Exactly. For our 56-year-old patient on that new regimen, the rebound risk is significant. So ongoing vigilance, checking glucose maybe every 30 minutes for a few hours, sometimes longer, is absolutely crucial for safety. We need to prevent another dangerous drop. It's not just about fixing the crisis. It's about ensuring they stay stable.
Okay, that makes total sense. So we've covered the emergency stuff. Let's take a step back now and just define our terms. We keep saying low blood sugar, but what does low actually mean, like in medical numbers? Are there specific thresholds that say, okay, this is hypoglycemia? Does it differ for people with diabetes versus those without?
That's a fundamental question,
Yeah.
absolutely. So for patients with diabetes, we generally define hypoglycemia as a blood glucose level of 70 milligrams per deciliter, mgdl or less. That's about 3.9 millimoles per liter if you use those units.
70. Okay, that's the magic number.
It's the general alert threshold, yes.
Mm-hmm.
But we actually break it down further into levels, which helps guide what we do. Level 1 hypoglycemia is anything less than 70 milligdl, but still above 54. That's your alert level.
Okay.
Level 2 is when it drops below 54 milligdl. That's considered clinically significant hypoglycemia. It usually means we need to be a bit more aggressive with treatment.
Below 54. Got it.
And then there's level 3, severe hypoglycemia. This one isn't defined by a specific number. It's defined by the state of the patient specifically, needing help from another person to recover because their cognitive function is impaired. They can't treat themselves.
So level 3 is about needing assistance regardless of the exact number.
Precisely. Now, it's really important to understand, while 70 is that clinical alert, the level where someone actually feels symptoms can vary quite a bit between people. That's a key point.
Ah, okay. So not everyone feels it at 70.
Not necessarily. And for people without diabetes, the definition is a little stricter. We generally say it's a blood glucose below 55 milligdl combined with symptoms. If a non-diabetic has a low reading but feels totally fine, it might not be true hypoglycemia, but it would definitely raise an eyebrow and need looking into.
Symptoms are key for non-diabetics then. You mentioned symptoms a few times, and I've definitely heard of something called the Whipple triad. Sounds like a classic diagnostic thing. What exactly is it, and how does it help nail down that the symptoms really are from low blood sugar?
Whipple's triad. Yes, it's a classic, incredibly useful diagnostic tool, especially when you really need to be sure that the symptoms are directly caused by the low glucose. Think of it like a three-legged stool. You need all three legs for it to stand.
Okay, 3 parts. What are they?
First leg. The patient has signs or symptoms consistent with hypoglycemia. That's when they feel shaky, sweaty, confused, or what someone else sees, like disorientation or unresponsiveness.
Right, the things we've been talking about.
Second leg. You need an objectively low blood glucose level measured right when those symptoms are happening. So for diabetics, typically under 70. For non-diabetics, under 55. That finger stick is crucial here.
Okay, symptoms plus a low number.
And the third leg, this is the clincher, relief of those symptoms when the blood glucose goes up after treatment. This confirms the cause and effect. If they feel better once their sugar normalizes, bingo. You know the low sugar caused the problem.
Ah, so the symptoms going away after treatment is part of the diagnosis itself?
Exactly. It ties it all together. Historically, Whipple first described this in the context of insulinoma, that rare tumor making too much insulin, so it's been a cornerstone for diagnosing conditions like that for a long time.
That really clarifies it. Now, you mentioned earlier that the symptom threshold varies. Not everyone feels it at the same level. Why is that? Why might one person feel awful at 65 while someone else doesn't notice anything until they're way down at, say, 45? That sounds incredibly dangerous, actually.
It is incredibly dangerous. And that variability is one of the trickiest parts of managing hypoglycemia. While, yes, most adults tend to get symptomatic around 50 milligdl, it can be wildly different. The biggest reason for this, especially in people with type 1 diabetes or long-standing type 2, is a condition called hypoglycemia-associated autonomic failure, HAO for short.
HAF. Okay, what does that mean?
So here's where it gets, well, really interesting and frankly quite worrying. With HAF, basically repeated episodes of low blood sugar start to change how the body responds. It kind of rewires the autonomic nervous system's counter-regulatory response.
Rewires it.
Think of it like a car alarm that keeps going off falsely. Eventually you tune it out, or maybe the alarm itself just gets less sensitive, right?
Oh, okay.
Normally, when your sugar drops, your body pumps out stress hormones like epinephrine, adrenaline. That causes the shakiness, the sweating, the racing heart. Those are your built-in warning bells screaming, eat something.
The body's alarm system.
Exactly. But with the HAF, because the body's seen low sugar so many times, that alarm system gets blunted. It takes a much lower blood sugar level to trigger enough adrenaline to cause any symptoms at all.
Wow. So the warning signs just disappear.
Or come much later.
They often come much later, or sometimes they're barely noticeable. This leads to what we call asymptomatic hypoglycemia, or hypoglycemia unawareness. And it's profoundly dangerous because people lose those critical early warnings. They don't feel shaky or sweaty.
So what happens instead? How do they know?
Often the first sign is a neuroglycopenic symptom Confusion, disorientation, slurred speech, maybe even passing out. Their brain isn't getting enough fuel, but they missed all the early alarms. It's like the low fuel light on your car is broken. You don't know you're low until the engine sputters and dies.
That is genuinely scary. Can anything be done about HAF? There's actually some good news there. And this is a key point from recent ADA guidelines. This unawareness often can be reversed, or at least improved. It takes effort, though. Usually about 2 to 3 weeks of strict hypoglycemia avoidance, really working to keep blood sugar consistently above, say, 80 milli-GDL, can help retrain the body's response and bring back some of those warning symptoms.
So avoiding lows can help fix the problem of not feeling the lows.
In many cases, yes. It gives the system a chance to reset.
Are there other things that affect symptom awareness?
Definitely. Certain medications are notorious for masking symptoms. Beta blockers are a prime example.
Used for heart conditions, right?
Yes, and high blood pressure. They work by blocking the effects of adrenaline, which means they can block those warning signs like a racing heart or tremors. If you're on a beta blocker and have diabetes, recognizing hypoglycemia becomes much harder. It's critical that both doctors and patients are aware of that interaction.
So communication is key there.
Absolutely. It just highlights why education about hypoglycemia unawareness is so vital. Helping patients recognize even subtle signs, maybe a slight change in concentration or mood, can empower them to act sooner and hopefully prevent a severe episode.
That whole HEF concept is a huge insight. So if your body's natural alarm might be unreliable, knowing the actual signs and symptoms, even the quieter ones, becomes absolutely critical. Let's dive deeper. What does hypoglycemia actually feel like? What are the specific things clinicians are looking for, or that someone experiencing it, or maybe their family, might notice?
Knowing the specifics is crucial, you're right, for self-awareness and for spotting it in others. We generally group the symptoms into 2 main categories based on what's happening physiologically.
Okay, 2 groups.
First, you have the neurogenic or autonomic symptoms. These are the result of your body activating its fight-or-flight response, releasing those stress hormones like adrenaline to try and raise blood sugar.
The body's immediate reaction.
Exactly. And within this group, you have symptoms from increased sympathetic activity. That's the adrenaline rush. Think tremor, that shaky feeling. Pallor, where someone looks pale. Feeling anxious or intensely nervous. Tachycardia, a fast heartbeat. Sweating, often a cold, clammy sweat. And palpitations, feeling your heart pound. These are often the first things people notice.
Classic warning sign.
They are. Then, still under autonomic, you can have symptoms from increased parasympathetic activity. This might show up as intense hunger, almost ravenous. Paresthesia is that tingling or numbness, often around the lips or fingertips. And sometimes, though less often, nausea or even vomiting.
Hunger and tingling, too. Okay, what's the second group?
The second group, and these are generally more concerning, are the neuroglycopenic symptoms. These happen because the brain itself isn't getting enough glucose, its main fuel.
Neuroglycopenic, brain sugar lack, basically.
Pretty much. The brain is a glucose hog. It needs a constant supply. When that supply dips, brain function starts to falter pretty quickly. And the symptoms can be really varied, sometimes even mimicking a stroke or psychiatric issues, which is why that quick glucose check is vital.
What kind of symptoms are we talking about here?
Things like agitation, confusion, noticeable changes in behavior. Maybe someone becomes unusually irritable or silly or even aggressive. They might seem really fatigued, dizzy, have trouble concentrating, or develop problems with coordination like stumbling.
So cognitive and behavioral changes.
Yes. And if the hypoglycemia gets worse or lasts longer, it can lead to really serious neurological problems. Seizures can happen. Or focal neurological signs, that means weakness or numbness just on one side of the body. Or maybe visual changes, again, potentially looking like a stroke.
Wow, that's serious.
It is. And the progression can be quite predictable if it's not treated. From somnolence, just being very drowsy, to obtundation, where alertness is significantly reduced, then stupor, where they're barely conscious, only responding to maybe painful stimuli, and finally, coma, deep unconsciousness.
That's a terrifying progression.
It is, and prolonged severe hypoglycemia, if left untreated, can cause actual irreversible brain damage. And in the worst cases, it can be fatal. This really hammers home the critical point. Any change in mental status, especially in someone with diabetes or known risk factors, needs an immediate fingerstick glucose check. And if it's low, treatment without any delay. We're talking about potentially saving brain cells minute by minute.
That urgency really comes through. It's not something to wait on. Now, we keep linking this mainly to diabetes, understandably. But can people without diabetes get true hypoglycemia? And if they do, what does that usually mean? It seems like it would be a different situation entirely.
That's a really important distinction to make. Yes, while hypoglycemia is far, far more common in people with diabetes, it's actually quite rare in those without it. But when it does happen in someone without diabetes, it should always trigger a thorough investigation for an underlying disorder
Always. Why?
because it's not normal. In a non-diabetic person, the body has robust systems to keep blood sugar stable.
Mm.
If those systems fail to the point of causing symptomatic low blood sugar, it signals that something significant is wrong with their glucose regulation. It's a major red flag, often pointing towards a potentially serious, undiagnosed medical issue. Which naturally leads to the question, for you, the listener,
Yeah.
once you've handled the immediate low, what kind of underlying problems could this point to? And how do doctors figure that out?
Exactly my next thought. So let's go back to our 56-year-old patient. The immediate crisis is over. His sugar levels are coming back up. He's stable. What happens next? You can't just pat him on the back and send him home without figuring out why it happened, right?
Right.
Investigating that root cause seems absolutely crucial.
You're absolutely right. Stabilization is just step one. Once the patient is stable, the whole focus shifts. We need to play detective and figure out the why to prevent it from happening again, potentially worse next time.
Yeah.
And how we investigate really depends on whether the patient has diabetes or not.
Okay, so different paths depending on their history.
Precisely. Let's start with patients with diabetes. In almost all cases, their hypoglycemia is linked to either an acute illness bumping things off kilter, or more often, it's medication-related. Insulin, sulfonylureas, those usual suspects.
Right.
So if we can quickly find an obvious trigger, maybe our patient admits he accidentally double-dosed his new med, or he clearly has pneumonia raging, then generally an extensive workup isn't needed right then. The cause is found. The solution is adjusting the meds, treating the infection, education.
Makes sense. If the cause is clear, fix the cause.
Exactly. But if there isn't an obvious trigger, if he says, nope, took my meds correctly, feel fine otherwise, then we dig a bit deeper. We'd run routine labs, a CBC blood count, a BMP metabolic panel to check caries and electrolytes, liver function tests, just to get a broader health picture.
Looking for hidden problems.
Right. And if we suspect an underlying infection, even if it's not obvious, we might do a septic workup, chest x-ray, urine tests, blood cultures, just in case. In rare situations, if nothing adds up and we suspect a factitious disorder, someone intentionally causing their lows.
Someone making themselves sick.
Yes, perhaps by secretly taking extra insulin or pills they have access to. It's sensitive, but we might check specific blood levels for sulfonylureas or outside insulin sources. It's complex.
Okay, so that's for patients with diabetes. What about those without diabetes? You said it's rarer, but always needs investigation. What does that look like?
That's a much more involved process because, like we said, it's uncommon and usually signals something significant. First, we have to meticulously rule out major medical crises. Is there severe liver failure, kidney failure, heart failure? These can all disrupt glucose control. We also need to rule out drugs known to cause lows, including alcohol, very carefully.
Checking all the big, obvious possibilities first.
Yes. We also ask about surgical history. Has the patient had gastric bypass surgery recently? That can cause delayed hypoglycemia, something called late dumping syndrome.
Okay. What if all those are ruled out? The person seems generally, well, not critically ill, no obvious drug cause.
If they seem relatively well, but they're having these unexplained hypoglycemic episodes, then we strongly suspect an insulinoma.
Insulinoma, that tumor you mentioned.
Exactly. A rare, usually benign tumor in the pancreas that just churns out insulin constantly, whether the body needs it or not, driving sugar levels down.
So how do you test for that?
We start with specific blood tests, drawn ideally during an episode of low blood sugar if possible. We measure insulin levels, C-peptide levels. C-peptide is released alongside the body's own insulin, so high insulin but low C-peptide suggests someone injected insulin, while high levels of both point to the body overproducing it. We also check proinsulin, an insulin precursor, and sometimes specific autoantibodies.
Okay, special blood tests. Anything else?
Yes, to really confirm an insulinoma, we might do more specialized tests, usually in the hospital under close watch. Things like a glucagon tolerance test, or the gold standard. A 72-hour supervised fast.
72 hours without eating. Wow.
It sounds tough, but it's very revealing. Someone with an insulinoma will keep pumping out insulin, and their blood sugar will drop dangerously low even after many hours of fasting, whereas a healthy person's insulin would shut off. It helps confirm the diagnosis.
That makes sense. It forces the issue.
It does. But it's crucial to circle back to a key point. By far, the most common cause of hypoglycemia overall, in anyone, diabetic or not, is still an overdose, usually accidental, of insulin or another glucose-lowering drug. Simple medication errors happen. That's always high on the list to rule out.
So always check the meds first, basically.
Always. Thorough medication reconciliation is step one.
What if our diabetic patient, though, had a low episode but swore they hadn't changed meds, hadn't overdosed, and didn't have an obvious infection? Are there more subtle things that could be going on?
Absolutely. If the obvious triggers aren't there in a diabetic patient, we broaden the search again. We start thinking about underlying conditions that might be messing with how their body handles the medication. For example, has their kidney or liver function declined recently, even subtly?
Ah, back to the organs.
Yes. If kidney function dips, the previously safe dose of a drug like a sulfonylurea might suddenly start building up because it's not being cleared properly. That leads to unexpected lows. So checking kidney and liver function is vital in these unexplained cases.
So the same dose becomes too much because the body isn't clearing it.
Precisely. Another thing is increased insulin sensitivity. Maybe they've lost a significant amount of weight or started exercising more. Their body might just be responding better to their usual insulin dose, making it effectively too strong now.
So good changes can ironically cause lows if meds aren't adjusted.
Exactly. It's not a change in the drug, but a change in the body's response.
Mm.
And then, yes, if all those physiological reasons are ruled out, we do have to consider the possibility of factitious disorder again, especially if they have access to meds. It requires a very careful, thorough, and compassionate approach. It really shows how many factors can interplay, doesn't it? Detailed history is key.
It really does. And discussing these subtle factors perfectly sets up our next bit. Because what's truly mind-boggling is just how many different pathways can lead to hypoglycemia. Let's try and map out that bigger picture, really break down all these various causes, both for people with diabetes and those without. It feels less like a single issue and more like a complex web, right? Far beyond just, oops, too much insulin.
It absolutely is a complex web. Understanding the breadth of causes gives you a real appreciation for how tightly glucose needs to be regulated. Let's dive into it, starting with the causes in patients with diabetes, since that's where we see it most often.
Okay, causes in diabetics first.
Right. Top of the list, as we've said, is issues related to insulin or other glucose-lowering meds. Accidental overdose is common, misreading a syringe, using the wrong insulin pen, forgetting you already took a dose. Factitious disorder, while rare, is in this category too. Even how you inject matters. Injecting insulin into muscle, IM, instead of fat, SKR, makes it absorb way faster, potentially causing a sudden drop.
Didn't know the injection site mattered that much.
Oh, it can make a difference. Then there's increased insulin sensitivity, like we discussed, weight loss, more exercise. These can make the old dose too strong.
Right, the body changing its response.
Exactly. Next up is decreased insulin clearance. This is mainly about kidney failure. If the kidneys aren't filtering well, insulin hangs around longer in the body, increasing its effect and the risk of lows.
Kidneys again, crucial.
Very. Then there are glucose-related factors. Simply fasting or skipping meals while still taking medication is a huge one. No incoming glucose, but the meds are still working. Chronic alcohol use fits here too because it directly blocks the liver from making or releasing glucose. Very risky combination with diabetes meds.
Alcohol's effect on the liver, right?
Yes. And as we talked about with HAA, prior episodes of hypoglycemia themselves can become a cause of future, more severe episodes by impairing that awareness system. It's a vicious cycle.
The HAAF cycle.
Correct. And finally, acute illness is a major trigger. Things like sepsis, bad infections like COVID-19, major trauma, severe burns, organ failure, they all put immense stress on the body, disrupt metabolism, and can easily lead to hypoglycemia, even if meds haven't changed. And we should always remember, older patients are generally more vulnerable to developing hypoglycemia and having worse outcomes, diabetic or not.
Okay, that's a pretty comprehensive list for diabetics. What about people without diabetes? You said it's rare, but what kind of things cause it then?
Right. The list for non-diabetics is different, often pointing to more serious underlying stuff. A big category is critical illness. Severe liver disease like advanced cirrhosis or acute viral hepatitis, where the liver just can't do its job of storing and releasing glucose. Kidney failure, heart failure, severe malnutrition can all do it too. And again, overwhelming sepsis, COVID-19, trauma, burns, these systemic crises can disrupt glucose control even without diabetes.
So severe illness is a major factor.
Definitely. Then you have conditions causing endogenous hyperinsulinism, meaning the body itself is making too much insulin. The classic example is insulinoma, that pancreatic tumor. Much rarer causes include NIPHS, non-insulinoma pancreatogenous hypoglycemia syndrome, where the pancreas oversecretes insulin without a distinct tumor, and NICTH, non-islet cell tumor hypoglycemia. That's where large tumors elsewhere in the body, like sarcomas, produce too much IGF-2, a hormone that acts like insulin. Really fascinating, though rare.
Wow, tumors making insulin-like stuff. Okay.
Then there are surgical causes. We mentioned gastric bypass surgery leading to late dumping syndrome. Other stomach surgeries, like gastrectomy or pyloroplasty, can sometimes alter gut hormones and cause reactive hypoglycemia, too.
So stomach surgery is a risk factor.
It can be. Autoimmune causes are another category, though very rare. Things like insulin autoimmune syndrome, IAS, where the body makes antibodies to its own insulin causing erratic levels, or antibodies to the insulin receptor. Complex stuff.
Autoimmune, okay.
And then, surprisingly, a whole bunch of drugs can cause hypoglycemia in people without diabetes. It's a long list. Certain non-selective beta blockers, some antimalarials like quinine, antibiotics like sulfa drugs and fluoroquinolones, the antifungal pentamidine, even some painkillers like indomethacin, blood pressure meds like ACE inhibitors, antiarrhythmics.
That is a long list. Drugs you wouldn't expect.
Exactly. It highlights how careful you have to be with medication reviews. Others include IGF-1 itself, lithium, heparin, it goes on. It shows how interconnected everything is.
No kidding. Any other categories?
Just a couple more main ones. Hormone deficiencies are important specifically. Lack of pituitary hormones, hypopituitarism, or adrenal hormones like cortisol, adrenal insufficiency, as these hormones normally help raise blood sugar. Exogenous hyperinsulinism, getting insulin from outside, can happen in non-diabetics too, either through factitious disorder or accidental exposure. And lastly, very rarely, genetic or congenital conditions present from birth. It's a huge spectrum, isn't it? Shows why the investigation has to be so thorough when it happens unexpectedly.
Wow, that is an incredible list. It really drives home how complex glucose regulation is and how many things can knock it off balance. So, okay, the patient, maybe our 56-year-old, is stable. You have a better idea of the cause. What does the ongoing care look like now? It's clearly not just about that initial IV dextrose fix, is it? How do you keep them stable and make sure they don't just crash again?
You're absolutely right. The initial fix is just putting out the fire. Subsequent management is about making sure it doesn't reignite and ensuring sustained stability. It's less about frantic action, more about careful observation and planning.
So monitoring is still key.
Monitoring remains absolutely critical. After that first treatment, we recheck their glucose within 15 minutes to make sure it came up. But that's just the beginning. We need to keep checking, often every 30 minutes for at least the first couple of hours, specifically looking for that rebound hypoglycemia.
Checking frequently for that rebound.
Yes, especially, as we mentioned, if the cause was a long-acting agent like a sulfonylurea or long-acting insulin, those drugs can keep working for 12, 24, even 48 hours sometimes. So for those patients, a 24-hour observation period in the hospital is pretty standard, maybe even longer. The risk just lingers.
24 hours just for observation sometimes. Wow.
It's necessary for safety with those particular agents. Now, beyond just checking, the goal of maintenance therapy is to keep their blood sugar consistently above 100 milli-GDL. We want stable, normal levels.
How do you achieve that?
If the patient is conscious and can eat, we give them long-acting carbohydrates, things like bread, crackers, maybe a small meal with complex carbs. These release glucose more slowly, providing a steadier supply.
So not just sugar, but actual food.
Exactly. Sustained energy. Now, if they keep having lows despite this, or if they can't eat, we might start a continuous intravenous dextrose infusion, usually something like D5NS, 5% dextrose and saline, or maybe D10. We drip it in slowly, adjusting the rate to keep their sugar in that normal range. Euglycemia is the goal.
Euglycemia, normal blood sugar.
Right. And of course, all this is happening alongside supportive care, which crucially includes treating the underlying cause we work so hard to find. And if, despite giving IV glucose, the patient's sugar isn't coming up or staying up like expected, that's a huge red flag.
What does that suggest?
It makes us immediately reconsider. Could there be something else going on? Undiagnosed sepsis, a serious toxin ingestion, severe liver failure we missed, adrenal crisis. We have to broaden the investigation again if the standard treatment isn't working. Always stay vigilant.
That makes sense. Don't get tunnel vision. So this leads to a really practical question, especially for patients and families after a scary event. When is it actually safe to go home? And when do they absolutely need to stay in the hospital for more watching? That must be a big decision point.
It's a critical decision, absolutely. Balancing safety with getting people back to their lives, there are fairly clear criteria we use.
Okay, so when is admission necessary?
Admission to the hospital is needed in several situations. If the hypoglycemia is refractory, meaning really hard to control, levels keep dropping despite treatment, then ICU admission might be needed for super close hourly monitoring and more intensive care.
ICU for the toughest cases.
Yes. Even if not the ICU, admission to a general hospital ward is usually necessary if, 1, the low was definitely caused by an overdose of sulfonylurea or long-acting insulin. Because of that prolonged risk, they need that extended observation, often 24 hours minimum.
Okay, those long-acting drugs mean admission.
Usually, yes. 2, if their neuroglycopenic symptoms, the confusion, drowsiness, weird behavior, don't clear up quickly even after their sugar normalizes, that suggests a more significant hit to the brain, needing more time and monitoring.
If the brain effects linger.
Right. 3, for non-diabetic patients who need that workup for the underlying cause, like ruling out an insuloma, starting those tests often requires being in the hospital.
Makes sense for complex workups.
4, if the patient simply can't eat or drink reliably, they need IV fluids and glucose support.
If they can't sustain themselves.
Exactly. And 5, very importantly, if there's suspicion of intentional overdose, admission is vital then for medical safety, but also for psychiatric evaluation and support.
Okay, clear reasons for admission. When can someone go home?
Discharge can be considered, usually after at least a solid 4-hour observation period where everything's been stable and uneventful, but only if several conditions are met.
What conditions?
The patient has to be completely asymptomatic for at least those 4 hours. No lingering signs of low sugar. They must have received thorough education about their meds, maybe reducing a dose if needed, how to recognize symptoms, what to do, how to use glucose tabs or gel.
Education is key.
Absolutely. And crucially, we need to ensure they have adequate social support at home. Is there someone there who can keep an eye on them, help if needed, make sure they eat? That safety net is really important, especially in the first day or two after an episode.
Having help at home matters.
It really does. The whole discharge planning process is comprehensive. We cover medications again, self-monitoring techniques, safety measures like medical IDs, carrying glucose. We give clear instructions on when to come back to the ER immediately. And we always ensure they have follow-up arranged with their primary doctor or diabetes specialist to manage things long-term and prevent this from happening again. It's a team effort. Hashtag outro.
This has been an incredible deep dive. We've really unpacked hypoglycemia from all angles, that immediate emergency response, figuring out the why behind it, and then that crucial phase of keeping things stable. Just to sum up some key takeaways for everyone listening.
Yeah, let's recap.
We learned hypoglycemia has tons of causes, but for diabetics, it's usually linked to insulin, sulfonylureas, or other meds. For non-diabetics, it's much rarer, often pointing to critical illness or maybe something unusual like an insulinoma.
That's a core distinction.
And while symptoms can start below 70 milli-GDL, when someone actually feels it varies a lot, especially with that hypoglycemia unawareness, HAAF, where the warning signs get blunted.
That unawareness is so important to recognize.
The symptoms themselves fall into those two camps. The autonomic ones, hunger, sweating, fast heart rate, and the neuroglycopenic ones affecting the brain confusion, behavioral changes, drowsiness, even seizures.
Autonomic first, then neuroglycopenic if it progresses.
And the absolute critical point, I think, for you listening, like any change in mental status, especially if there are risk factors like diabetes, needs an immediate glucose check-in treatment. Delay can cause brain damage.
Don't wait. Check the sugar.
Treatment is glucose oral if they're alert, IV dextrose, or IM glucagon if they're not.
Glucose is the cure.
Exactly.
You know, this whole discussion really highlights how quickly something seemingly simple like blood sugar can spiral into a genuine life-threatening emergency. Knowing all this, maybe the question for you, the listener, to ponder is, what steps can you take now to be more tuned into your own body's signals, especially if you manage diabetes or care for someone who does? Or how can you be better prepared to step in and help if you suspect someone nearby is experiencing those early signs or even severe signs of hypoglycemia? It's more than just knowing the facts. It's about being observant, being ready, knowing when and how to act. Maybe it's keeping glucose tabs in your bag or making sure your family knows your specific warning signs and what your emergency plan is. Those small steps could make a huge difference one day.
That's a really powerful thought to leave everyone with. Being prepared, being observant. Fantastic challenge. Well, thank you for joining us on the deep dive today. We really hope this armed you with some valuable, practical knowledge and sparked your curiosity to keep learning.
Always more to learn.
Absolutely. We'll be back soon with another deep dive into the world of information.